So today we're going to go over antiarrhythmics. This can be a bit more daunting compared to other topics in school, so I did my best to break it down and also throw in a crap ton of mnemonics. Thank you as always for the support for the channel, for the nice comments, for buying a t-shirt, any support at all for the channel. I truly do appreciate it, so thank you so much. Let's go ahead and get started with antiarrhythmic drugs. So there are four main classes that you need to know, and that's your class 1 sodium channel blockers, class 2 beta blockers, class 3 potassium channel blockers, and then class 4 calcium channel blockers. If you ever forget which class is which, remember the sentence: some block potassium channels. First letters SBPC, class 1 sodium channel blockers, class 2 beta blockers, class 3 potassium channel blockers, and class 4 calcium channel blockers. All right, let's get started. We're going to start with our sodium channel blockers, but before we do, I want to review the cardiac action potential, as it's the foundation to understand how this first class works, as well as some of our other ones we'll talk about. So the cardiac action potential, it's complicated, and to make it even more complicated, it varies depending on which part of the heart we're talking about. We have an action potential in our pacemaker cells, as well as our cardiomyocytes and the cardiac muscle, but I'm going to try to make this as simple as possible. Let's first start with the action potential of the cardiomyocytes. Now, before breaking down each phase, there's a few simple facts to keep in mind. First, there are 5 phases: 0, 1, 2, 3, and 4. Next, there are 3 players in the game: 3 major ions, sodium, calcium, and potassium, all positively charged. And then finally, at rest, the inside of the cardiac cell sits at about negative 90 millivolts, making it relatively negative compared to the outside. All right, so let's break it down, starting with phase 4, which I like to call the floor. Phase 4 is the floor. This phase is the resting membrane potential. The cell at this time is really electrically quiet. There's some leakage of some ions, but overall, to keep it simple, just remember phase 4 as the floor, not much happening. Then comes phase 0. This is where the action starts. Fast sodium channels open up and sodium rushes into the cell, causing the inside to become rapidly more positive. This phase causes this rapid depolarization and creates a sharp upstroke on the graph. Phase 0, just remember, is all about sodium and depolarization. Next is phase 1, a brief but important moment. Sodium channels close and potassium, the party pooper as we'll call him, begins to exit the cell. This leads to a slight dip in the membrane potential known as initial repolarization. Phase 2, potassium keeps leaving like the party pooper that he is, but calcium starts to enter the cell at the same time, which essentially balances things out, and that's why phase 2 is known as the plateau phase. Ultimately, though, the calcium channels eventually close and potassium, of course, keeps leaving, leading to a rapid drop and repolarization, which is phase 3, this big old drop. And then eventually the cell returns to its negative resting state, and we're back at phase 4, the floor. Okay, so now that we have a general understanding, let's start with our class 1, our sodium channel blockers. So the meds in this class, well, there's a lot of them, and they're even broken into subsections, making it even worse. Class 1A, 1B, 1C. I know learning antiarrhythmics sucks. I feel you. But I do have a mnemonic, though, a tried and true mnemonic. So let's start. Class 1 is going to be Disopyramide, quinidine, procainamide. Class 1B is lidocaine and mexiletine. Then Class 1C, flecainide and propafenone. So how the heck can you remember that? They all sound different. Well, there's a tried and true mnemonic that goes double quarter pounder, lettuce, mayo, fries, please. Double quarter pounder, lettuce, mayo, fries, please. Know this mnemonic really well. So starting with your Class 1A drugs, double quarter pounder, DQP stands for disopyramide, Q stands for quinidine, and P stands for procainamide. Now, I've got a little twist to this mnemonic that's going to help you remember a key feature of these 1A drugs that you cannot forget. Picture your double quarter pounder not on a regular hamburger bun. Instead, imagine it stuffed inside a foot-long hot dog bun. A double quarter pounder and a foot-long hot dog bun. It sounds odd now, but trust me, it will make sense soon. Okay, next is our Class 1B drugs. Lettuce, mayo, LD stands for lidocaine and mexiletine. And then fries, please. Flecainide and propafenone, Class 1C. So that's how you remember the meds in this class. Now let's talk about how they work on that cardiac action potential we discussed before of the cardiomyocytes. So these are sodium channel blockers. So if we think about our cardiac action potential, where do we think the main impact would be? When did sodium, the party animal, join in? So phase 0, our big spike, depolarization. So when we add a sodium channel blocker to a patient with an arrhythmia, we decrease sodium influx, and it's kind of like cutting the gas of the engine and slowing things down a bit. We slow down the influx of sodium during phase 0, and by slowing phase 0 depolarization, we slow conduction velocity, and this can suppress ectopic beats, interrupt reentrance circuits, helping to restore normal rhythm. Now here's where it gets a little tricky. So these meds are all sodium channel blockers, but they all impact sodium in varying degrees. Some are potent sodium channel blockers, some are weak sodium channel blockers, some even block potassium. So let's keep this as simple as possible. So starting with our Class 1C drugs, which bind the tightest and longest, making them the most potent sodium channel blockers, causing the steepest reduction in and phase 0 upstroke. And even though they stretch out our phase 0 upstroke, they don't really change the action potential duration. The action potential duration, by the way, is just the total time it takes for the cardiac cell to complete one cycle from phase 0 depolarization to the end of phase 3 repolarization. Next are class 1A drugs, which produce intermediate blockade, producing a moderate slowing of phase 0, but most importantly, they also block potassium. Sneaky little guys. This lengthens the effective refractory period and the action potential duration, resulting in QT prolongation, which is going to cause some issues we'll go into more depth about in just a few minutes. And then finally, class 1B drugs, they bind and release quickly, so their effect on phase 0 upstroke is minimal. They also decrease the refractory period a bit, which can shorten the action potential duration. So I do have an easy way for you to remember the different subclasses and their strength of impact on the sodium channels, simply by remembering the more salt in the food, the more it blocks sodium. So remember our mnemonic: double quarter pounder, lettuce, mayo, fries, please. So out of all of these, which has the least amount of salt? Double quarter pounder, lettuce, mayo, or fries, please? So lettuce, mayo, right? So class 1B, lidocaine and mexilotine have the least sodium channel blocking activity. Next, which of these foods has the most salt? The fries. So fries, please. Class 1C, flecainide and propafenone exert the most potent sodium channel blockade among the class 1 agents. Finally, that leaves us with our double quarter pounder, class 1A, which has moderate amount of salt or moderate amount of sodium. So these meds, disopyramide, quinidine, and procainamide, have moderate sodium channel blocking activity, and that's how I remembered it. There are other mnemonics, but the salt thing just made sense for me and worked. Okay, next thing I want to go over is a few high-yield things to know about each of these meds, starting with our class 1A sodium channel blockers. So class 1A, remember, is our double quarter pounder, disopyramide, quinidine, procainamide. Now, before I told you, remember, this double quarter pounder is on a foot-long hot dog bun, and you probably already have an idea of why I said that at this point. So all class 1A drugs are notorious for prolonging the QT interval. So things like torsade de pointe, a dangerous form of polymorphic VTAC, are possible with these meds, and that's because, like we went over before, in addition to blocking sodium channels, they also block potassium, prolonging the action potential. And they're the only subclass of sodium channel blockers that do this. So class 1A drugs, you have to know they can prolong the QT interval. So very important and very likely a test question. So how can you remember that? Well, back to our mnemonic: double quarter pounder on that foot-long hot dog bun. So when you remember double quarter pounder, disopyramide, quinidine, procainamide, you'll remember that double quarter pounder is on a foot-long hot dog bun, and that's because all of these drugs can prolong the QT interval. So that double quarter pounder, oddly, on that foot-long hot dog bun helps you remember class 1A drugs prolong the QT interval. Nice and simple, don't forget it. Let's talk about quinidine first. Now, I know we just said all of the meds in class 1A prolong the QT interval, but quinidine really prolongs the QT interval. Quinidine has historically been one of the most common causes of drug-induced torsade de pointe, and the only reason it isn't still at the top of the list today is simply because we don't use it much anymore. It has a poor side effect profile, and they're safer meds. There is still some utilization in recurrent VTAC and Brugada syndrome and short QT syndrome, and I'll give you a second to think about why we might use this drug to treat short QT syndrome. But overall, usually it's not going to be a top pick. With that being said, you still got to know it because in addition to potentially causing torsade de pointe, it has a unique side effect that's often tested on. So the highest yield thing you need to know about quinidine is that it can cause something known as synchonism. Weird name, but here's the backstory, which may help you to remember it. So there is this tree called the cinchona tree, native to the Andes. It produces bark that's rich in alkaloids. This bark is not only the source of quinidine, but also the source of quinine, which you're probably familiar with for its treatment of malaria. So both of these meds, which come from the same tree, share a side effect profile from their plant origin, synchonism, which can cause a constellation of symptoms: tinnitus, hearing loss, confusion, delirium, visual disturbances, and we call this synchonism as it's named after the tree it's derived from, the cinchona tree. So hopefully that little backstory helps you to remember that quinidine can cause synchonism and, of course, torsade de pointe. Next drug from class 1A, it's much higher yield, and that's procainamide. Procainamide is another effective antiarrhythmic drug that's, again, limited by its side effect profile. And there's two things you need to know about procainamide that are very high yield: Wolff-Parkinson-White and lupus. Let's talk about that. So procainamide can be used to treat arrhythmias associated with Wolff-Parkinson-White. This is a popular exam question, so know it. Next, this drug can cause lupus-like syndrome or drug-induced lupus. So chronic administration of procainamide can lead to lupus-like syndrome. So these patients will have similar symptoms to those seen in lupus, rash, arthritis, etc. So these are the two things to know about procainamide. Can treat Wolff-Parkinson-White arrhythmias, can cause drug-induced lupus. How do you remember that? Well, instead of remembering it as procainamide, remember it as protrainamide. So every time you hear of procainamide, I want you to instead remember it as protrainamide and have this picture in your head of a big train rolling down the tracks. At the front of the train, the conductor is a wolf with bright white fur. That's your cue for Wolff-Parkinson-White. And this train is circling in this continuous loop, like one of those little kids' trains tracks, which will help you remember lupus-like syndrome. In a loop, lupus-like syndrome. So procainamide is protrainamide. Think of a train being driven by a white wolf, Wolff-Parkinson-White, circling in a continuous loop, lupus-like syndrome. Our last drug in the 1A class is Disopyramide, which I remembered instead as Disopyramide, dry, DRY, because the only thing I think you should know about this drug is it will dry you out because it causes anticholinergic side effects, which is the most common adverse drug reaction. So it can cause dry mouth, dry eyes, urinary hesitancy, constipation. So avoid this med in patients that have glaucoma, myasthenia gravis, etc. Remember, Disopyramide. Next is class 1B. What are our class 1B drugs? So that is going to be lettuce and mayo, which is lidocaine and mexiletine. Starting with lidocaine. So lidocaine, when administered intravenously, can be used for the treatment of ventricular arrhythmias. Most common ADR is going to be CNS toxicity. Then we have mexiletine, which is essentially an oral version of lidocaine. It can also cause CNS toxicity, but because it's a PO med, we often see GI problems, nausea, vomiting, or heartburn. Not important. What you should know about these two meds is that when they are prescribed, it will be for fast and failing ventricular tissue. So ventricular tachyarrhythmias post-MI. So if you're going to use these meds, it will be in fast ventricular rhythms, so ventricular tachycardia, ventricular fibrillation, and or on failing ischemic tissue. So ischemic arrhythmias after a myocardial infarction, for instance. And that's because the class 1B meds preferentially bind sodium channels in the depolarized and inactivated state, which are common in ischemic myocardium and during tachyarrhythmias. So drugs like mexiletine can be used for arrhythmia suppression post-MI. Lidocaine can be used in our ACLS algorithm. So main takeaway, class 1B, remember, use these drugs in fast and failing ventricular tissue, ventricular tachyarrhythmias, and post-MI. Okay, that leaves us with our class 1C drugs. Remember, that's going to be fries, please. So flecainide and propafenone. So these drugs can be used in both ventricular arrhythmias and supraventricular arrhythmias like atrial fibrillation, atrial flutter. There's something known as the pill-in-the-pocket approach, which is a form of pharmacologic cardioversion. Basically, a patient with history of AFib is at home, feels an episode coming on. They can pop one of these combined with an AV nodal blocking agent like a beta blocker to get themselves back into rhythm. So that's cool, but really the most important thing to know about this subclass and what I want you to remember is that these drugs are contraindicated in patients with structural heart disease, like post-MI. They are only to be used in patients with structurally normal hearts. Using these drugs in patients with structural heart disease, coronary artery disease, etc., can lead to sudden cardiac death. Quite the opposite of the class 1B drugs we just went over, where that was one of their primary indications. And it's a very easy test question. So how can you remember that 1B drugs are good post-MI and class 1C drugs are bad post-MI? Well, back to the same mnemonic. If you just had a heart attack and you're ordering some dinner, you're going to substitute your fries for a salad, right? So remember that class 1B, lettuce mayo, good post-MI. Class 1C, fries, please, no good post-MI. Remember, after a heart attack, substitute the fries for a salad. So that's your sodium channel blockers. Quick recap. Drugs in this class are remembered by the mnemonic: double quarter pounder, lettuce, mayo, fries, please. Double quarter pounder, disopyramide, quinidine, and procainamide, class 1A. Lettuce, mayo, lidocaine, and mexiletine, class 1B. Fries, please, flecainide, and propafenone, class 1C. These drugs slow down the influx of sodium during phase 0, and remember, the more salt in the food, the more it blocks sodium channels. Remember, your double quarter pounder is on a foot-long hot dog bun to help you remember your class 1A drugs can prolong the QT interval, torsade, etc. Remember, quinidine can cause synchronism. Procainamide, aka protrainamide, remember your white wolf driving the train on a loop track, Wolff-Parkinson-White, and lupus. Class 1B, lidocaine and mexiletine used on your fast and failing ventricular tissue. And class 1C, flecainide and propafenone. Most importantly, remember these drugs are contraindicated with structural heart disease, post-MI, etc. Remember, after an MI, substitute your fries for a salad. And that's your sodium channel blockers. Next, let's talk about class 2, which are beta blockers. You're probably familiar with this class as we also use these meds for hypertension as well as a number of other indications. And if you ever forget which med is part of class 2, remember B is the second letter of the alphabet. Beta blockers, B, class 2. So these drugs, in addition to their antihypertensive properties, also have antiarrhythmic properties. Luckily, remembering the names of these meds is a whole lot easier compared to your sodium channel blockers because all of these drugs end in LOL. So all beta blockers end in LOL, and most, but not all, end in OLOL. And here's something important I want you to recognize. If you see a beta blocker that doesn't end in OLOL, does not end in OLOL, you need to know that this is going to be a unique or fancy beta blocker that does something a little extra. So if a beta blocker does not end in OLOL, it's usually because it has extra properties beyond standard beta blockade, like alpha blockade that we see in carvedilol and labetalol, which end in ILOL and ALOL respectively, or potassium channel blockade that we see in sotalol, which ends in ALOL. So when you see a beta blocker, check the suffix. If it ends in OLOL, like metoprolol, it will act primarily through standard beta blockade. If it ends a little differently, like labetalol, ALOL, you'll know it has some additional properties beyond standard beta blockade. Now, how do these drugs work? So for that, let's look at our cardiac action potential again, but this time we're going to be looking at our cardiac action potential of our pacemaker cells. So a little different. This action potential only has 3 phases, 0, 3, and 4. So starting at phase 4, which before we called the floor, as this was almost a flat period with not much happening. Now you'll notice phase 4 is much different, and that's because phase 4, we now have this slow leak of sodium sneaking through these pacemaker channels. This is sometimes called the funny current. In addition, and very important, during phase 4, we also have calcium influx, first through T-type calcium channels and then through L-type calcium channels, which ultimately depolarize the membrane to its threshold potential. Next, phase 0, we have calcium continuing to enter through, producing a slower upstroke than the fast sodium-driven spike of our cardiomyocytes we were talking about before. And then finally, phase 3, repolarization as calcium channels close. And guess who starts to leave again? Yep, potassium, the party pooper, flows out, bringing us back to phase 4 once more. As you can see, our pacemaker cells lack a distinct phase 1 or 2. All right, so now that we understand the pacemaker action potential, how do beta blockers influence this to help treat arrhythmias? Well, indirectly by preventing epinephrine and norepinephrine from binding to the beta receptors. So how does this help us treat arrhythmias? So in the heart, we have beta receptors, primarily beta-1 adrenergic receptors, and when catecholamines like epi and norepi bind to these receptors, this long chain of events occurs. First, the enzyme adenylyl cyclase is activated, which converts ATP into CAMP. CAMP activates pKa, which phosphorylates L-type calcium channels, causing them to open, leading to an influx of calcium. What do you need to remember from that? It's just that when epi and norepi bind to these receptors, a bunch of stuff happens, which leads to more calcium in the cell. So if we block these beta receptors with beta blockers, we block epi and norepi from binding, slowing the influx of calcium at the end of phase 4, decreasing this slope, making it take longer for the cell to reach the action potential threshold. And in turn, the SA node fires less often because of this, and the AV node conducts more slowly, both of which help control heart rate and are especially useful in treating tachyarrhythmias like atrial fibrillation. Now, beta blockers also have effects on non-pacemaker cells like cardiomyocytes, and in these cells, by decreasing calcium influx, they decrease cardiac contractility, decreasing oxygen demand for these cells. So this is a lot of info, but here's the simple recap of what you should know in a few words. Beta blockers stop epi and norepi from binding, which indirectly decrease calcium influx, flattening our phase 4 slope. Now, what are the common indications for this class of drugs you should know? Of course, beta blockers are used in a number of different conditions, but when it comes to their antiarrhythmic indications, the one you should know is for rate control in atrial fibrillation and atrial flutter. They can also be used in SVT, post-MI, MAT, etc., but please remember rate control in AFib and aflutter. That's the most common and most important. Okay, so now I want to go over some extra tips for beta blockers and some mnemonics. First thing that you should know is not all beta blockers are the same. We have cardioselective beta blockers that primarily just block beta-1 receptors in the heart, and then we have non-selective that also block beta-2 receptors, which can be found in smooth muscle cells, GI tract, uterus, but most importantly in the lungs, where they can induce bronchodilation when stimulated. Remember the mnemonic, beta-1 primarily found in the heart, you have one heart, beta-2, which can be found in the lungs, you have 2 lungs. Just helps to remember it. Now there's a bunch of beta blockers, so how the heck can you remember which are cardioselective and which are non-selective? Well, remember that a beam of light is selective to just one area. A beam, BEAM, is selective to just one area. So if the beta blocker starts with a BEAM, it's cardioselective. So that's going to be bisoprolol or betaxolol, esmolol, atenolol or acebutolol, and metoprolol. So you don't even need to remember all of the specific names. Just remember a beam of light is direct or selective light, meaning if a beta blocker in the question starts with a B, E, A, or M, it's cardioselective. So if they ask you a question, something like you decide to treat this patient with a beta blocker who has a history of mild to moderate bronchospastic disease, which would be the preferred beta blocker to use, You want to find one that starts with a B, E, A, or M, as the cardioselectivity makes this a safer drug for this population. So this is great for exam knowledge, but in real life, you should be aware that even cardioselective agents can exert some inhibition of beta-2 receptors at high doses. So if you had a patient with severe or decompensated bronchospastic disease, you'd want to avoid all beta blockers in these patients, selective or non-selective. Okay, next, I want to segue into a mnemonic to help you remember the contraindications/warnings of this class of drugs. So to help you remember the most common and tested on, remember the mnemonic ABCD. So ABCD stands for asthma, bradycardia, cardiogenic shock, diabetes. So let's go over those one by one. Let's start with A for asthma. We just talked about this before, so I'm not going to go into great detail, but beta blockade with non-selective agents prevents bronchodilation, so non-selective beta blockers should be avoided in susceptible patients, asthma, etc. And in severe disease, you really want to avoid all beta blockers, even the selective agents. Next, B stands for bradycardia. These meds have negative chronotropic effects. They slow the heart rate, so they're relatively contraindicated in symptomatic bradycardia, sinus node dysfunction, and in patients with second or third degree AV block, unless a pacemaker is present. C stands for cardiogenic shock or severely decompensated heart failure. While beta blockers improve survival in stable chronic heart failure, initiation should be avoided in severe acute decompensation or cardiogenic shock, as in these states, the heart depends on the sympathetic drive, the beta-1 stimulation to maintain output, which beta blockers shut down, so blocking beta-1 receptors reduces contractility and heart rate, worsening shock. Finally, the D stands for diabetes. This is more of a caution rather than a contraindication, but one that's important to know. So beta blockers can mask hypoglycemia symptoms like sweating, anxiety, which are mediated by epinephrine, which they block. They also may delay recovery from insulin-induced hypoglycemia by blunting epinephrine's effects on gluconeogenesis and glycogenolysis, although the studies are a bit more conflicting in this area. But main takeaway, use these in cautions with diabetics. All right, so that's your beta blockers. Quick recap of the juicy details of our class 2 antiarrhythmics. Remember, the second letter of the alphabet is B, and beta blockers, which start with a B, are our class 2 antiarrhythmics. All drugs in this class end in LOL, and most end in OLOL. The ones that don't got something special about them. Beta blockers block epi and norepi from binding to our beta-1 receptors in the heart, indirectly decreasing intracellular calcium influx, decreasing the slope of phase 4. The main indication I would know is for rate control in AFib and A-flutter. Remember your cardioselective beta blockers with BEAM, bisoprolol, betaxolol, esmolol, atenolol, acebutolol, metoprolol. Finally, remember your common contraindications warnings for beta blockers with ABCD, asthma, bradycardia, cardiogenic shock, diabetes. That's your beta blockers. Let's talk about our class 3 antiarrhythmics next, which are our potassium channel blockers. So there's a few different drugs in this class: amiodarone, dronedarone, abutolide, dofetilide, sotalol. Honestly, you should really just focus on amiodarone and maybe sotalol, but there is a mnemonic to help you remember all of them. The mnemonic is, well, and I'm sorry for this, but it's AIDS, AIDS. A stands for amiodarone, I stands for abutolide, D stands for dofetilide and dronedarone, and S stands for sotalol. And to further solidify this mnemonic and help you remember the AIDS mnemonic is associated with potassium channel blockers, you can also remember the sentence, can't cure AIDS with potassium, with can't and cure spelled with a K instead of C to remember the chemical symbol for potassium. I apologize, it's not the most appropriate mnemonic, and the mnemonics from here on out, well, you'll see. All right, so how do these drugs work? Well, for that, we need to go back to our cardiac action potential of the cardiomyocytes we were discussing before, the one with 5 phases. So remember potassium, the party pooper who kept leaving the party and ultimately in phase 3 just flooded out, leading to repolarization. Well, what if we had a drug that can come in and just block the door, not let him out during phase 3, making him hang around? Well, that's our potassium channel blockers and our class 3 drugs, which block potassium efflux during phase 3, prolonging phase 3 repolarization. So these drugs bind and inhibit potassium channels, meaning we have less potassium leaving the cell, which leads to a slower rate of repolarization, prolonging the action potential and the effective refractory period. This increase in the refractory period helps because this essentially lengthens the period of time this cell can hang out before being stimulated again. We give it a little breathing room, which helps interrupt reentrant arrhythmias. Now, the problem with prolonging things, prolonging the action potential in particular, is we get a new problem. And I'll give you a second to think about what that problem may be. What was another med class or subclass we talked about that also blocked potassium? It involved a foot-long hot dog bun. That's right, our class 1A sodium channel blockers, the double quarter pounder on a foot-long hot dog bun, also blocked potassium, and they led to the same issue we'll go over now, which is prolonged QT interval with the potential of developing torsade de pointe. So a significant adverse effect that you need to be aware of for these medications. Of note, this is much less common with amiodarone and dronedarone compared to the other meds in this class. But you need to remember your class 3 potassium channel blockers can prolong QT interval, and so can your class 1A sodium channel blockers we went over before. Please remember this as it will likely be tested on. All right, moving on. What are the indications for our class 3 drugs? So some indications are for atrial fibrillation, atrial flutter, ventricular tachycardia. Amiodarone, really the only one you should focus on, is a powerful antiarrhythmic drug used both for atrial and ventricular arrhythmias, limited only by its side effect profile. Orally, it's most often prescribed to prevent atrial fibrillation and ventricular arrhythmias. Intravenously, it's used in critically ill patients with AFib to restore sinus rhythm, control ventricular rate, or convert ventricular arrhythmias. And like lidocaine, it also plays a key role in our ACLS protocol. So let's talk a bit more about amiodarone, because I feel like if you're going to get a question about a class 3 antiarrhythmic, it's going to be on amiodarone. And not only that, amiodarone is just an interesting drug. So first, remember amiodarone instead of amiodarone as am3-odarone. So instead of am-e-odarone, remember am3-odarone, as in the number 3. So a year from now, when you forget all about this whole lecture and you get a test question that has amiodarone on it, if you always remember it as am3-odarone, you'll never forget it's a class 3 antiarrhythmic. Now, on that note, even though this medication is classified as a class 3 antiarrhythmic, as it does block potassium channels, it also blocks sodium channels like a class 1, beta-adrenergic receptors like a class 2, and calcium channels like a class 4. Pretty crazy. Dronedarone, another class 3 drug, which is structurally similar to amiodarone, just lacking the iodine group, also blocks all 4 channels. So maybe not a super high yield thing to know, but pretty cool. Okay, next let's cover potentially the highest yield thing to know about amiodarone, and that's its adverse effects. So amiodarone is a highly lipid-soluble drug. It accumulates in all different tissues throughout the body, which is part of the reason it has so damn many side effects. Oral amiodarone also has a super long half-life, hangs around for 100 plus days in some cases. So this is probably the highest yield thing to know about amiodarone, its adverse effects. So how can you remember the adverse effects of amiodarone? Because there's a lot. Well, unfortunately, all of the class 3 and 4 drug mnemonics are inappropriate, and it's not on purpose. It's just what works out with the letter, so I'm sorry. All right, so for the adverse effects, remember, taking amiodarone is a BITCH. Taking amiodarone is a BITCH, which stands for blue skin, interstitial lung disease, thyroid toxicity, corneal deposits, hepatotoxicity. So starting with B, amiodarone can cause blue skin. Amiodarone could cause a bluish-gray discoloration of the skin, sometimes called blue man syndrome. This is going to be most prominent on the face. There's other skin issues, photosensitivity, hyperpigmentation, but don't forget about the blue skin. Next, the I stands for interstitial lung disease. Amiodarone-induced pulmonary toxicity is found in up to 5% of patients. The most common form is interstitial pneumonitis. So before you start a patient on amiodarone, you should obtain a baseline chest x-ray to ensure there isn't any evidence of existing interstitial lung disease. Next is probably the most important one, and that's thyroid toxicity. Thyroid toxicity, so amiodarone contains high amounts of iodine. That's actually the reason the name amiodarone contains the letters IOD. It's due to the fact amiodarone contains 2 iodine atoms per molecule in its chemical structure. And since iodine is a key substrate for thyroid hormone synthesis, this iodine load can disrupt thyroid function, leading to either hypo or hyperthyroidism. Thyroid dysfunction is actually one of the most common complications of amiodarone therapy, and because of this, patients should have baseline thyroid function tests such as TSH before starting the medication and should be monitored periodically during treatment. Next is corneal microdeposits. So these microdeposits occur in the majority of patients taking amiodarone. They're typically benign and don't affect visual acuity, and they result from amiodarone being secreted into the tears by the lacrimal glands and gradually accumulating on the corneal surface, and they generally resolve after discontinuation of the drug. Finally, hepatotoxicity. So around 25% of patients taking amiodarone will have a transient rise in serum aminotransferase concentrations, our liver function test. So AST, ALT can go up. Most patients are asymptomatic. Hepatitis occurs in fewer than 3% of patients, and cirrhosis and hepatic failure are rare. So add this to your checklist of the many organs you'll need to check before starting amiodarone. So baseline LFT should be obtained prior to initiation, as well as checking during therapy. All right, so remember, taking amiodarone, as you can tell, is a BITCH, blue skin, interstitial lung disease, thyroid toxicity, corneal deposits, hepatotoxicity. One other class 3 med I want to briefly mention before we wrap this up is sotalol. So before I tell you why this med is unique, I want you to look at the name and think, what is unique about it? It's spelled SOTALOL. First, it ends in LOL, so it's a beta blocker. But remember what we talked about before with beta blockers. If they end in OLOL, traditional beta blocker, anything else, we know they have some additional properties. So sotalol ends in ALOL, so we know there's more than just traditional beta blockade with this med, and in this case, it's pretty obvious as we're talking about potassium channel blockers right now, so we know sotalol also has potassium blocking abilities in addition to beta blockade, and that's why it's considered a class 3 med. Later on, when you see this on an exam question, though, you'll likely remember it's a beta blocker due to the LOL at the end, but it's easy to forget it's also a potassium channel blocker. So because of that, I used to remember instead of sotalol as sopotalol. The POT helps me remember that in addition to being a beta blocker, it's also a POT, potassium channel blocker. So remember it instead as sopotalol. All right, that's our class 3 antiarrhythmics. Remember the meds by remembering the mnemonic AIDS, AIDS, amiodarone, abutolide, dofetilide, dronedarone, and sotalol. You can't cure AIDS with potassium. Remember they block potassium efflux during phase 3, prolonging phase 3 repolarization. These drugs can prolong the QT interval with the potential of developing torsades. The highest yield med to know is amiodarone. Remember it instead as am3-odarone. To help you remember, it's a class 3 antiarrhythmic. And to remember the super high yield adverse drug reactions, remember taking amiodarone is a BITCH. Blue skin, interstitial lung disease, thyroid toxicity, corneal deposits, hepatotoxicity. And finally, remember sotalol is a beta blocker as well as a class 3 potassium channel blocker. Remember it as sopotalol instead of sotalol. Let's move on to our class 4 drugs next. So our class 4 calcium channel blockers. So this is actually much easier because there's only 2 meds to know, and that's verapamil and diltiazem. And if you need help remembering, these 2 meds are class 4 meds, and I'm sorry, another inappropriate mnemonic, I did warn you. But remember the sentence, fornication leads to venereal disease. Fornication leads to venereal disease. Fornication helps you remember class 4. Venereal disease, which starts with VE and DI, help you remember verapamil and diltiazem, which also start with VE and DI. Fornication leads to venereal disease, helps you remember your class 4 meds are verapamil and diltiazem. Now, the next question you might ask yourself is, class 4 meds are calcium channel blockers. Why do we only have 2 meds listed? What about all of the other calcium channel blockers like amlodipine, nifedipine, etc.? Why are we only discussing diltiazem and verapamil? So for that, we need to quickly review the different types of calcium channel blockers and what they do. So there's 2 different types of calcium channel blockers. We have non-dihydropyridine and dihydropyridine. Non-dihydropyridine are diltiazem and verapamil, which we're going to go over in more detail in a moment. And dihydropyridine are all of the others, amlodipine, nifedipine, nicardipine, etc. The nice part about this is dihydropyridine ends in INE, and so do all of the dihydropyridine calcium channel blockers, amlodipine, INE, nifedipine, INE, etc. The non-dihydropyridine meds are the non-INE meds, diltiazem, verapamil, that don't end in INE. So it's a nice and easy way to differentiate the two. So to keep this brief, both of these subclasses inhibit the L-type calcium channels on cells, which we'll go over in more detail in a sec. But the big difference is that dihydropyridines are INE meds, amlodipine, nifedipine, etc., primarily target the calcium channels on vascular smooth muscle tissue. So they're great for treating hypertension as they cause vasodilation of these vessels, reducing systemic vascular resistance, but they exert minimal direct effects on the myocardium. That's where our non-dihydropyridine meds come in, the ones that do not end in INE, diltiazem, and verapamil. These meds do the same. They inhibit L-type calcium channels, but they're more selective for the pacemaker and non-pacemaker cells of the heart, making them useful for the arrhythmias we'll go over. So let's talk a bit more about how these non-dihydropyridine meds work, our class 4 agents. So the main effect is on the pacemaker action potential. So like we were talking about before, the pacemaker action potential only has 3 phases, phases 0, 3, and 4. And let's just do a quick recap because why not? It's a tough subject. So class 4 is a slow sodium leak through the funny current, with calcium entering first through our T-type calcium channels and then through L-type calcium channels to push us to reach threshold potential. Class 0 is the slower calcium-driven upstroke of depolarization. Phase 3 is repolarization as calcium channels close and potassium, the party pooper, flows out. So unlike beta blockers, which indirectly affect the calcium channels by blocking epi and norepi, calcium channel blockers directly impact calcium channels and impact phase 4 and 0. So they decrease calcium entering during phase 4 and 0 and will have a decrease in the slope of phase 4 and 0, slowing things down. So the heart gets a little more breathing room, and just like in beta blockers, they'll decrease firing of the SA node, decrease conduction velocity through the AV node, which helps to treat our arrhythmias. Like beta blockers, calcium channel blockers also have effects on calcium influx in non-pacemaker cells, like our cardiomyocytes, decreasing the force generated during contraction. So they have effect not only on cardiac conduction, but also cardiac contractility. So remember, calcium channel blockers block calcium channels, just as the name states, which affects phase 4 and 0 of the pacemaker cardiac action potential. Now, what arrhythmias do they treat, you might ask? Well, since they're similar to beta blockers, we will see some similarities. Diltiazem and verapamil are both used for acute and chronic ventricular control in atrial fibrillation and atrial flutter. They're also effective for supraventricular tachycardia alongside adenosine and can be used in multifocal atrial tachycardia as well. But the main indications to remember are rate control in AFib and aflutter and SVT. All right, what else should we know about calcium channel blockers? Well, of course, you got to know the adverse drug reactions. So the 3 adverse effects you need to know for non-dihydropyridine calcium channel blockers are constipation, cardiac block, bradycardia, which luckily is the initials of calcium channel blockers, CCB. So starting with the C for constipation. This occurs in up to 25% of patients. Next C is cardiac block. So these drugs may cause first, second, or third degree AV block. Finally, the B, which is our last letter, these drugs may lead to sinus bradycardia, so you should avoid these drugs in patients who are using other AV nodal blocking agents like beta blockers, patients with sick sinus syndrome, or patients with underlying AV node dysfunction. All right, that's our class 4 antiarrhythmics. Not a whole lot to know. Our calcium channel blockers. Remember the meds in this class by remembering fornication leads to venereal disease. Class 4, verapamil and diltiazem. Remember, these are non-dihydropyridine agents. They decrease calcium entering during phase 4 and 0. Indications are rate control in AFib and aflutter, SVT. Remember your adverse drug reactions by remembering CCB, constipation, cardiac block, bradycardia. All right, if you're still with me, congrats. That was a lot. So that was your class 1 through 4 antiarrhythmics. I'm going to do a 60 or so second recap of the highest yield topics in mnemonics, and then we'll do a few quick questions to test your knowledge. So 4 classes of antiarrhythmics to know: Class 1, sodium channel blockers; Class 2, beta blockers; Class 3, potassium channel blockers; Class 4, calcium channel blockers. Remember them by remembering the sentence, some block potassium channels. Starting with Class 1, sodium channel blockers, which slow the influx of sodium during phase 0. And remember, the more salt in the food, the more it blocks sodium channels. Remember, Class 1 has 3 subclasses: Class 1A, disopyramide, quinidine, procainamide; Class 1B, lidocaine and mexilitine; Class 1C, flecainide and propafenone. Remember your double quarter pounder, lettuce, mayo, fries, please. Remember our Class 1A meds, double quarter pounder, are on a foot-long hot dog bun to help you remember the Class 1A drugs prolong the QT interval. Super important. Don't forget about procainamide, aka protrainamide, your white wolf driving a train on a loop track, wolf, Parkinson, white, and lupus. Remember our Class 1B meds are indicated for fast and failing tissue like post-MI, but our Class 1C meds are contraindicated post-MI. Remember, after a heart attack, you swap the fries out for a salad. Next, Class 2 beta blockers. Remember, the second letter of the alphabet is B, and beta blockers, which start with a B, are our Class 2 antiarrhythmics. All drugs in this class end in LOL, and most end in OLOL. The ones that don't got something special about them. Beta blockers block epi and norepi from binding to our beta-1 receptors in the heart, decreasing calcium influx and the slope of phase 4. The main indication I would know is for rate control in AFib and aflutter. Remember your cardioselective beta blockers with BEAM, bisoprolol, betaxolol, esmolol, atenolol, acebutolol, metoprolol. Finally, remember your common contraindications/warnings for beta blockers with ABCD, asthma, bradycardia, cardiogenic shock, diabetes. Next, Class 3 potassium channel blockers. Remember the meds by remembering the mnemonic AIDS, AIDS, amiodarone, abutolide, dofetilide, dronedarone, and sotalol. They block potassium efflux during phase 3, leading to prolonged phase 3 repolarization. QT prolongation is an important adverse effect to know. The highest yield med is amiodarone. Remember am3-odarone to help you remember it's a Class 3 antiarrhythmic. And to remember these super high yield adverse drug reactions, remember taking amiodarone is a BITCH. Blue skin, interstitial lung disease, thyroid toxicity, corneal deposits, hepatotoxicity. And finally, remember sotalol, it also blocks potassium as well as being a beta blocker. So remember it as sopotalol. Finally, our Class 4s, remember the meds in this class by remembering fornication leads to venereal disease. Fornication, Class 4, venereal disease, verapamil, and diltiazem. Remember, these are non-dihydropyridine agents. They decrease calcium entering during phase 4 and 0 in nodal cells, prolonging phase 4 and 0. Indications, rate control in AFib and aflutter, SVT. Remember your adverse drug reactions by remembering CCB, constipation, cardiac block, bradycardia. That's your antiarrhythmics. Let's do 5 quick questions to test your knowledge. Question 1. Which of the following antiarrhythmic drugs has the most potent impact on blocking sodium channels in the myocardium, leading to the greatest reduction in the slope of phase 0 depolarization? A. Lidocaine, B. Mexilitine, C. Flecainide, D. Disopyramide, or E. Verapamil? So that is going to be C, flecainide. So which of these meds has the most potent sodium channel blocking activity? We have 5 choices, and one of them we can knock out right away. Answer E is verapamil, which is a class 4 calcium channel blocker. So let's eliminate that option. So then we're left with 4 choices: lidocaine, mexiletine, flecainide, and disopyramide, which are all sodium channel blockers. And if we remember the mnemonic, all we have to do at this point is find the saltiest food, and we'll know that has the most potent sodium channel blockade. So let's think about the foods and how salty they are. First, lettuce mayo, the least salt, the weakest sodium channel blockade, class 1B. Double quarter pounder, moderate amount of salt, moderate sodium channel blockade, class 1A. Then finally, fries please, the saltiest, the strongest sodium channel blockade, class 1C. So fries please represents propafenone and flecainide, and only flecainide is present in the answer choices, so we know answer C, flecainide, is the correct choice, which is a class 1C agent exerting the most potent sodium channel blockade and the strongest impact on reducing the slope of phase 0. Question 2. A 58-year-old man who was recently started on a new medication by his cardiologist presents to the emergency department. After beginning therapy, he reports episodes of dizziness and near syncope. An ECG obtained in the emergency department shows a markedly prolonged QT interval followed by polymorphic ventricular tachycardia with a characteristic twisting of the QRS complexes around the isoelectric baseline. Which of the following medications is likely responsible for this patient's presentation? A, lidocaine, B, diltiazem, C, quinidine, D, mexiletine, or E, metoprolol. So that's going to be C, quinidine. So this question is describing a patient with prolonged QT and polymorphic ventricular tachycardia with twisting QRS complexes, so torsade de point. So which medication classes that we've covered today are most likely to cause prolonged QT and torsades? And you got to know this. That's your class 3 potassium channel blockers and your class 1A sodium channel blockers. So now that we know which drugs to look for in our answers, let's start first with your potassium channel blockers. We remember those drugs with the mnemonic AIDS: AIDS, amiodarone, ibutylide, dofetilide, dronedarone, sotalol. None of these are present in the answer choices. So next, let's search for our class 1A drugs. Remember your double quarter pounder on a foot-long hot dog bun, which represents disopyramide, procainamide, and quinidine. Quinidine, which is answer C, a class 1A drug that, as we discussed before, is notorious for prolonging the QT interval and causing torsades, is the most likely cause of this patient's presentation compared with the other medications, and this is the correct answer for question 2. Question 3. A 64-year-old man was started on a new antiarrhythmic medication several months ago. At a routine follow-up, he reports new fatigue and notices bluish-gray discoloration of the skin over his face. Laboratory studies reveal an elevated TSH as well as an increase in serum aminotransferase concentrations, AST and ALT. Which of the following medications was most likely initiated in this patient in the past few months? A, dofetilide, B, sotalol, C, amiodarone, D, flecainide, or E, verapamil? So that's going to be C, amiodarone. So the correct answer is C, amiodarone, and you better know this one. Remember, amiodarone messes with so many different organs in the body, and it's why there are so many monitoring parameters needed when initiating and continuing on this medication. Chest x-ray, thyroid function test, serum aminotransferase levels, etc. So amiodarone can cause a number of different adverse effects. The main ones, though, are in the mnemonic BITCH, because taking amiodarone is a BITCH. Blue skin, which is seen in this patient, interstitial lung disease, thyroid toxicity, which we see here evident by the increase in TSH, as well as the complaints of fatigue likely secondary to hypothyroidism, corneal deposit, and hepatotoxicity that we also see in this patient with the increase in AST and ALT. So don't forget, taking amiodarone is a BITCH. The other drugs, while they may have some adverse effects seen in this patient like hepatotoxicity, amiodarone is the only one to potentially have all of these clinical manifestations. Okay, question 4. A 70-year-old man with a history of hypertension and atrial fibrillation presents to the clinic complaining of recurrent palpitations. He is hemodynamically stable and his ECG confirms atrial fibrillation. After failing other therapies, the patient is started on an oral medication that primarily prolongs phase 3 repolarization of the ventricular cardiac action potential, increasing the action potential duration and effective refractory period. Which of the following medications was most likely initiated in this patient? A, lidocaine, B, metoprolol, C, dofetilide, D, verapamil, or E, mexiletine? So that's going to be answer C, dophenyline. This ain't an easy question, but let's break it down. First, avoid all the noise. The only part of this vignette that matters is which drug in this list prolongs phase 3 repolarization, increasing action potential duration, and effective refractory period. And by definition, that is a potassium channel blocker, which in this case, the only potassium channel blocker listed is dophenyline, the D in AIDS. The other meds, B-metoprolol is a class 2 beta blocker, mainly affects phase 4 of pacemaker cells. Lidocaine and mexiletine, our lettuce and mayo meds, are class 1B sodium channel blockers, which act on phase 0. And then finally, D-verapamil is a class 4 calcium channel blocker, which primarily affects phase 4 and 0 of nodal cells. All right, our last question, question 5. A 64-year-old man with a history of atrial fibrillation is being managed for rate control. He was previously prescribed a calcium channel blocker, which was discontinued due to intolerance. The treatment plan now shifts to a beta blocker. His medical history includes mild, well-controlled asthma managed with occasional albuterol inhaler use. Which of the following beta blockers is the most suitable option for rate control in this patient? A, propranolol, B, nadolol, C, pindolol, D, metoprolol, or E, timolol? So that's going to be D-metoprolol. So we have a patient with history of AFib and mild bronchospastic disease. He did not tolerate calcium channel blockers, so we're going to start him on a beta blocker. Non-selective beta blockers hit both the beta-1 receptors in the heart as well as beta-2 in the lungs, which can cause bronchoconstriction, so these are not recommended in patients with bronchospastic disease like asthma. A selective agent, on the other hand, at lower doses will hit primarily beta-1 receptors and can be used with caution in this patient population. So the only question you need to ask yourself at this point is which is a cardioselective beta blocker. And the easy way to know this is to remember a beam of light is direct and find a beta blocker that starts with B, E, A, or M. In this case, that would be metoprolol, which is a cardioselective agent and the correct answer for this patient. All right, so that was antiarrhythmics. It is a lot. I hope that helped you, and thank you so much for watching the video, and thank you so much for the support of the channel.